All right, Si, thanks for joining me again. Um, I guess you've had an interesting time the last few months. Some people lauding your work, others heavily criticizing it. How are you getting on now?
Uh, yeah, well, thanks, Cliff, for having me. Yeah, it's been a really interesting time. I think there's no doubt about it. I'm in the minority, but I think science is not a numbers game. It's about trying to get to the truth. So even though I may be in the minority, I think there's some important evidence that I keep coming back to, and I think it's important that this evidence gets out into the public domain. I've been critical of the government strategy of eliminating COVID-19. I think it's a very unlikely strategy to succeed, and I think when you subject it to cost benefit analysis, it looks very unfavorable compared to other things one might choose to do with one's money to improve health in this country. And the other concern I have is for a vaccine. The elimination strategy in itself is a very low probability of sustainable success, in my view. I think we were very lucky to get away with the 100 days of no COVID cases, and I think New Zealand has done some things very well in its response to COVID. But in terms of the long term, we need to think about where does this strategy take us, and forever closed or at least firmly restricted travel, the threat of ongoing lockdowns and the financial implications of those. To be honest, I find them quite frightening as a New Zealander to be in a country where that is the government's current policy.
Yeah, and I think it's prudent, right at the outset, given what you've just said, to just sort of make that distinction and clarify between legitimate dissenting academics like yourself and maybe people who we might say are on the lunatic fringe who are, really taking these conspiracy theories to heart, the 5Gs and, the sort of this being sort of co-opted by a fairly strong anti-science, anti-vax movement. But in reality, they are so separate from what basically all legitimate academics are talking about. You would actually be closer to the government position than many of them, right? In some respects. I mean, you're certainly not saying that this doesn't exist or it's a conspiracy or it's been engineered by Bill Gates to depopulate the world, any of that crazy stuff. So I think it's disingenuous when critics of you and others are placing you in the same bundle as those people, because then that's just a way, to my mind, to sort of squash debate.
Yeah, well, look, I strongly believe that some vaccines have been useful. We no longer have the threat of polio in New Zealand, and that that was a big thing just a couple of generations ago. And I had teachers that were affected by polio, and now we simply don't have it, and that is due, in my view, to the vaccine. So I'm certainly not anti-vaccine. Sorry. But what I am concerned about is over-optimism about vaccines, and that's something that I've seen in the medical community for some time. For example, the flu vaccine is often touted as a very effective strategy for reducing flu every year. And actually, if you look at the evidence in the Cochrane reviews, you see that the the benefits of the vaccine are way overblown, and it's much more highly promoted than really the evidence suggests. Other vaccines, MMR, it's very clear during the measles epidemic that the majority of cases were unvaccinated people, and that strongly suggests that measles is a very effective vaccine. So just like everything, the truth is somewhere in between here, but I think, but what concerns me is a government policy which is strongly predicated on a vaccine coming, a vaccine that we don't have. We've had coronaviruses, we've had severe coronaviruses with us for over a decade, and we've known about coronaviruses for 40 years, and we've never had a vaccine. And yet the government policy on its website is talking about a vaccine, an effective vaccine in the next 2 years. We know that vaccines are not especially effective for elderly people. There's a major problem in the vaccine community called immunosenescence, which occurs in frail elderly people. And they are the target group for protecting against COVID-19. And so you've got these insurmountable barriers. And although I'd love us to get through those barriers, I just know that the probability of doing that is very low. And we know other vaccines take the gold record in terms of timelines for vaccine development is for mumps. And that was 4 years.
Yeah.
Most are 10. So we now have immunologists telling us, and these are guys who've devoted their whole lives to vaccines, telling us that it's unrealistic. And so, at some point we need to ask these questions. How realistic are these policies? And these are in black and white on the government website, and no one seems to be asking the hard questions here.
Well, that's been, I guess, one of my biggest concerns around this, because I'm fairly orthodox, I'm fairly well in the middle. I like to think I'm pretty pragmatic. On balance, I'm pro-vaccine because most of them work incredibly effectively, all those sorts of things. So I would say that I'm relatively conservative with respect to a lot of my views around health. But one of the worrying things for me has been this sort of, it's almost as if there's this groupthink that's occurred, whereby if there are people trying to have legitimate conversations around this and speaking to the numbers and asking questions about the longer term implications, they're shut down, or they're attacked ad hominem, which I think is, to me, academic debate is sacrosanct, and you don't indulge in those academic or logical fallacies if you can avoid it. I wanted to ask a couple of questions about that, because I think it's really important. I really want to get into the numbers as well, but do you believe that this situation has led to some academic suppression of, maybe yourself or other academics, people in academia trying to sort of silence academics who are asking these questions?
Well, yeah, we've certainly experienced that. Senior colleagues have told us not to speak up. And
just to be clear for people listening, that's illegal, right?
Well, as an academic, under the Education Act, you have a right to free speech within your academic specialty. So as long as you stay within your lane,
right,
you are entitled to share your opinions.
And I think we would agree that is a hallmark of modern democracy, right? That's an important thing, to have both academic freedoms and press freedoms. And I don't know, because there is no hard evidence that I have access to, but I've certainly heard from a number of people, including people in government, that there have been some, I guess to put it lightly, some pressure exerted on certain media outlets to maybe promote or sync various stories. Is that something that you can speak to as well?
Well, I really, one of the interesting issues that's happened during this unusual time is some conversations that I've had with journalists. And I've had several conversations for over an hour with journalists, kind of going over the evidence that I've presented that COVID-19 has been overblown, that some of the claims have been exaggerated, and particularly the mortality claims and infection fatality rates, for example. And the journalists kind of tell me, why are you not doing more? And I kind of giggle at that point, because I feel like I've been doing as much as I can, and I then look at what some of the stories have been, and that come out from the same journalists that I've had the conversations with, and they're generally suppressing the evidence that I'm presenting.
Yeah.
So I think, one thing I've become aware of is the sort of Twitterati, and the response that you get from sharing your opinions on social media, and how that can lead to self-censorship. And I think
Absolutely.
that's a thing. I actually don't think there's a huge government conspiracy around this.
No.
I think it's, that there has been this very dominant story, and it's tapped into certain things that we'd all like to see achieved. Like, we'd like to see New Zealand lead the world, and we would like to see the virus eliminated. We all would. I mean, I would. But we also have to ask ourselves at the same time, how realistic is that, and where does it lead us?
Yeah.
And what are the costs of this strategy? How likely is it to succeed? And is it going to be overall beneficial in the long term? And to me, the evidence is strongly pointing that that's not the case.
Yeah, and I think the questions around government overreach, I think we also need to make a couple of things clear. And, I've had people say to me, well, a lot of the narrative coming out from media as a ubiquitous sort of thing is actually more right-leaning. And so it's more sort of pro-national, let's say. And I think that's true, but that doesn't mean that there is not also potentially some suppression of things that are contrary to what people see as in the public good. And so both those things can exist at the same time. And I'd also like to make clear, from my point of view at least, and I'm not speaking for you here, but from my point of view, I don't see this as a partisan issue. And the reason being that I'm a person who's concerned about government overreach, not because of what I think will happen here, but just because of the possibilities that could occur. And for anyone to look for examples of that, we can see, for example, in Eastern Europe, COVID has been used as an excuse to further concentrate and persecute Romani populations in Eastern Europe. We know that COVID's being used in China as a sort of mask for further suppressing the Uyghur minority there as well. And so it's not as if we don't have examples right now, and also examples in history, where certain things can be enacted and then maybe subsequently they end up being expedient for maybe less benevolent governments. It was in many respects fairly benevolent US presidents who enacted or who really started to overuse executive power. And then maybe leaders who came in afterwards would use that for maybe more nefarious purposes. So I don't want to go down the rabbit hole there. I just think we need to be cautious enough to not just always have that tendency to fall into line without having those checks and balances. And to my mind, the checks and balances are press freedoms and academic freedoms, academic debate. So
Absolutely, Cliff. Look, I want to stay away from the politics of this. I think that's a whole other area. My area really is the science, and
yeah.
the science is the justification for the policies. And so my viewpoint really is that the science doesn't justify the policy, and or at least the policy has a very, very low likelihood of success. And so that's the argument that I'm pushing. I mean, in terms of government overreach, I think, I'm legitimately concerned about that, as you are, but it's not really my area of speciality.
No, fair enough. And I'm probably, because I'm not currently employed by any academic institution, I guess I have the freedom to say whatever the hell I want, which is kind of nice. But let's get into the numbers a little bit, because that's the most important thing. Now, it seems to me that there is a soft walking back of the elimination strategy anyway, although it's not being overtly specified. I mean, the fact that we have, albeit small, but active community transmission here, and yet the level was still downgraded. It does seem to me like there is a bit of a walking back. Do you believe that's occurring? And obviously you don't believe that elimination is a viable strategy anyway. So do you think that the government is starting to walk back that position now?
I think it's very hard for me to second guess what the government is doing. It's certainly, I think the government has realized that the costs of lockdown in pursuit of elimination are astronomical, and that the cost benefit analysis that, even the government's done itself, if you look at the Productivity Commission report, about 95-1, and that's the government's own advisors. And I think that's the benefits are quite generous in that document. So I think there's definitely been talk of avoidance of ongoing lockdowns, but in terms of strategy of elimination, it still seems to be an overarching policy. It's been talked about from the Prime Minister down. It's still on the government website. The border strategy is certainly related, has that in mind. And all the top government advisors are still talking about elimination. So to me, that is a critical issue, because, although it would be nice to eliminate the virus, we have to think about the downsides. We've spent $50 billion in New Zealand so far. Yeah. We have to ask ourselves, where's that how are we going to pay that $50 billion back?
Yeah. Okay, so let's look into how things have changed a little bit, because that's obviously, one of the most important things. We need to constantly reevaluate the evidence. When this started emerging, there were some pretty high numbers thrown around, particularly for case fatality rates. And, I'd like to talk about infection fatality rates as well, but starting with CFR, originally from memory, people were talking about even 6 or 8% CFR, and it's obviously a lot lower than that now. I think based on the latest data that I was looking at from Oxford and the data compiled by OWID, we're looking at, on confirmed cases versus confirmed deaths, it's around 3-odd%, right, in terms of CFR. Is that relatively accurate?
Yeah, I believe so. It varies very widely between countries. I actually made an app, which I think is not working now. I need to put some attention to it. But you see an incredible variation in terms of case fatality rate by country, and it seems to be strongly associated with testing rates and various other country factors like GDP,
right,
wealth of a country. So it's very hard to say that there's one case fatality rate that you can generalize to a whole country. There is such a wide spectrum.
So given that, have you done any modeling on what the infection fatality rate might actually be? And so for people listening who don't understand the difference, obviously the case fatality rate is the confirmed cases versus confirmed deaths, right? whereas the infection fatality rate would be an estimation of its actual fatality, because there's going to be a lot of asymptomatic cases or cases that aren't picked up.
Yes, well, I mean, that's been an interesting story in itself, because we've had antibody tests suppressed in New Zealand. We haven't done any antibody tests to my knowledge. I think there might be one study happening down in Southland. So antibody tests, which is the body's response to the virus, give us a totally different picture to the swab test that we're doing by sticking a swab up the nose. And so the nose swab test just tests for the presence of RNA of the virus. You know, it may be active, it may be, the body may be on top of the virus, but it's only if the virus is present at that particular time, whereas antibody tests tend to hang around a bit longer if you've had the virus in the past. So they give an idea of the spread of the virus.
And did you see that study? I think it was just reported today, where they were noticing antibodies much longer than had previously been thought. So we're sort of looking at 4 to 6 months post-infection.
Yeah, there's a bit of a complicated picture with antibodies. With many other standard viral infections in medicine, antibodies are almost a universal feature of infection, and they tend to stay with you lifelong. But for COVID, they seem to be time limited. So it looks like antibodies, which give us an idea of how widespread the virus has been, are a likely underestimate, because after a few months, you lose them. But anyway, with that in mind, that these are underestimates, and the T-cell research from the immunologist is showing that there's other responses, immune responses to the virus, that show that it's much more widespread than we've previously appreciated. So given all that, looking at the antibody responses, John Ioannidis, probably one of the most cited epidemiologists of all time, has put out a preprint, and he's collected all the case fatality, all the cases, deaths, serology results, and adjusted to estimate serology adjusted infection fatality rate. And he's come up with a figure of 0.2 as the median, 0.2%. So that's about 2 in 1,000. When we compare that to influenza, it's around about 1 in 1,000. So it looks like it's a bit more serious than seasonal flu, but not that much more serious. And certainly putting that information together, looking at mortality statistics, you've seen spikes in overall mortality in some countries, not in all heavily hit countries. When you look at the age distribution of deaths, you don't see, in New Zealand, you see no difference between the age distribution of deaths with COVID and the age distribution of deaths for any other cause in the year before. So you see that the virus...
And 2 years before is interesting from what I was looking at.
Oh, okay.
Because 2018 seemed to be a pretty bad year for mortality. And so a lot of people are comparing to 2020 to 2019. But in a lot of countries, it's actually pretty close to 2018.
Right.
And I'm not sure whether that was because it was a bad flu season or whatever. But yeah, it's just interesting eyeballing the numbers, because it's sort of, it doesn't seem to make sense. Because as you say, there was a spike. And I imagine that was also, tell me if I'm wrong here, but I imagine if that's also because this is more sort of transmissible, right? It's got a higher R number than influenza. So you would expect to see more people infected more quickly, and therefore it's almost like there's a surge in mortality, but not necessarily a greater increase or a markedly greater increase over a temporal period. Would that be fair?
Yes, yeah, I think that's the pattern that we're seeing. So, for example, if you read the press, you'll see that Sweden has had a 1 in 150 year spike in overall mortality, and that looks alarming. But if you look at overall counts of deaths over the first 7-8 months of 2020 in Sweden, you'll see that it's no more per capita than 2015. So this phenomenon is what we call displaced mortality in epidemiology. And I think, as time goes on and we compare the total numbers of deaths, we're going to see more and more evidence that what we're seeing is displaced mortality rather than, which suggests very few years of life lost from COVID.
And that would mesh with the sort of estimated CFR for, let's say, over 80s at the moment, which I think from memory was around 10%, as compared to actuary data, which shows that over 80, your likelihood of dying in a year is about 16%.
Yeah, well, I think one of the best analyses I've seen from that is David Spiegelhalter's analysis, where he shows that, and this was pretty early on before we had antibodies or anything, we were just looking at PCR positive cases, deaths divided by PCR positive cases. And he showed that the mortality rate by age was about the same as your annual mortality rate. So that he summarized it by saying that having COVID's like squeezing your annual mortality rate into 2 weeks where you have the virus and may recover. And he actually said that's probably a vast overestimate of the importance of COVID, because the COVID deaths have been people who've generally been much more, have had higher comorbidity than the average population of somebody at the same age. So that gives you a clue as to how important this disease is in terms of shortening life. As a worst case scenario, and all the information that we're getting recently with antibodies and T-cell tests is that even that is an overestimate.
So that's also, in some respects, a good rationale for the idea of a mitigation strategy and flattening the curve, right? Because if we did, let's say, compress mortality for certain groups into a very short period of time, there's hospital surge, and that's going to overwhelm capacity, right?
Yeah, well, I think that's the message I'm trying to convey, is that we need to be less obsessed with the counts of cases or infections. I think cases is kind of a misnomer, because we know the CDC is talking about 40% of people testing positive not having symptoms. The proportion in New Zealand is much lower because we're only testing people who have symptoms.
Right,
But,
of course.
So we, these are very, very sensitive tests. We know that if you stick a swab up people's nose and test for a bunch of viruses, it's almost universal if you test long enough and hard enough. I think studies have shown, longitudinal studies have shown, that about 2/3 of people, if you test them every week for a couple of years, they're going to show a PCR positive test for a virus. So what we need to think about is what you're saying. What are the health implications of this? How many people is it sending to hospital? How many people is it sending to ICU? What are the mortality statistics? And we know that hospital services and intensive care services have never been stretched in this country by COVID-19 cases. And so that's where I think the focus and the attention should be. We know now that that health services can adapt. There is capacity in health services. You know, you can cancel elective surgery and you've all of a sudden got a ton more beds. That you can rustle up some ventilators from elsewhere in the country. That the country has enough healthcare services to deal with this crisis.
So one of the criticisms of the sort of mitigation strategy that you've proposed is that there may be longer term complications from COVID. Reductions in cognition and, fatigue and all sorts of various longer term complications, maybe some effects on the cardiovascular system. I wonder that threat appears to be real based on some case studies, but I wonder what the effect of that is, what the magnitude of that effect is, because we do know that, viral illnesses do cause long-term complications. We've certainly seen that in research on influenza. We know of the post-viral effects of things like Epstein-Barr virus. So with respect to maybe similar or other viral infections, how real do you think that long-term effect of COVID is? And I guess there's not enough data at this stage to really say unequivocally, but what's your sort of sense around that?
Yeah, well, I think that is something that we need to watch and look for. But as you say, it's not unusual to get long-term fatigue and long-term symptoms after a viral infection. And I think, we're early in there's been a lot of excitement about rare complications of COVID-19, and so myocarditis and that sort of thing. But if you look at the details on that, there are a handful of cases. This is not, this is not the majority of cases by any means. So it's just a matter of keeping in perspective. I think we're all still learning a lot about the virus, about what is important, and certainly been stories about people having long-term complications. But we as an epidemiologist, I don't think there's enough information out there to tell me how common these are. And you introduced it by saying a criticism of the mitigation strategy. Well, the elimination strategy, even if we say we're going to eliminate this virus, doesn't mean that long term that's going to be effective and that we're going to be able to mitigate some of these complications. There's wildly different assessments of how effective lockdowns are, and you look between countries, and there's a paper in Lancet eMedicine which shows virtually no benefit at all from comparing countries that locked down with those that didn't. So,
So, I'm no epidemiologist. I'm no biostatistician, but I wanted to eyeball the numbers myself. And so I downloaded all that data and just ran it, through our very basic sort of iteration of R as well. And I was surprised myself because I thought maybe there wouldn't be a strong association, but there was there was nothing.
Yes. Yeah. Well,
even as someone who's not, anywhere near your level, just from a pragmatic point of view, I would think that given the amount of lockdowns that have occurred over a long enough period of time with large enough numbers, you would expect to see something.
Yeah, well, there's different threads of evidence here, Cliff. You got the between country evidence, which I think you're looking at. And you've also, I think, actually stronger evidence really is the within country evidence. So I compared the states in the United States. That's quite a good comparator, I think, because you've got at least what you hope is relatively similar ways of recording cases and deaths and ascertainment of cases and deaths within the country. And if you compare states that did lock down with states that don't, and I've got the data there that's live updating every day, And I look at the regression plane, and if you see a strong relationship with this plane, you think there's a relationship. What I've observed in the United States comparing lockdown and no lockdown, is on average, there's no difference in terms of cases or deaths per capita. So that is not strong evidence, in my view, that lockdowns work. Yet, there's almost a questioning that idea in New Zealand is, you almost get burnt at the stake.
When I was crunching some numbers and talking with some friends, a couple of them said to me, "Yeah, but you're looking at all these various countries, or places within the US, for example, and the borders are so porous that it doesn't really mean anything, right? Because people can get through, so it kind of homogenizes it a little bit." Anyway, this was the idea. So I did a little sub-analysis just for myself, looking at just island nations, basically. So states that had no contiguous borders with any other country, and it actually looked worse for those countries. The association was weaker. So that sort of set some red flags for me. But I mean, I guess at the end of the day, no one is saying that, well, we just shouldn't do anything. We should just, throw people under the bus. I sort of inferred from what you've said that we do need to continue to readjust the numbers. We need to be, continuing to look at any long-term implications, but we also need to be looking at just basically the cost to benefit analysis and the longer term cost to benefit analysis for society, but also for those most at-risk individuals. Because, knowing you personally and the type of person you are, I found it quite offensive when people were saying, well, Simon Thornley's just about the money, because you're probably one of the least about the money kind of people I know, right? I understood that a lot of your work was geared towards the longer term implications for those people most at risk, because a long-term economic downturn or not taking appropriate measures to really look at this pragmatically is probably going to adversely affect those most at risk, right? Particularly those in the Māori and Pacific communities and people at more risk of socioeconomic harm.
Yeah, well, my whole career has been dedicated to preserving life. But we have to realize that medical science and intervention and things that we think are working don't always have the effects that we assume. And so I've seen a lot in the government policy about lockdown and elimination being a pro-equity approach, and that Māori and Pacific people will be badly affected if the virus gets out. It's kind of unusual, since their age demographic is much younger than, on average, than European populations. Certainly they do have cardiometabolic risk factors that are higher than European populations. But anyway, what we've seen is that, throughout the lockdowns, we've seen food banks in South Auckland have demand outstrip supply. We've seen lots of people go on the benefit, and job losses in the hospitality and tourism sectors. So we've got to keep an eye on, whether our interventions are actually doing what we think they are doing.
Yeah.
My guess is that overall the lockdowns are not going to be pro-equity, and that they're actually going to hit the poorest New Zealanders hardest. And unfortunately, poorest Māori and Pacific people tend to be in that group. So I think the rhetoric of lockdowns and elimination being pro-equity just doesn't stand up to scrutiny.
No, I think it's pretty clear when we look at all things combined that there are few people who can make money or increase wealth during an economic recession, and those are the people who have wealth. So it's probably going to widen the wealth inequality and the wealth gap in New Zealand. I want to shift focus just a little bit because I know that you're relatively short on time. I wanted to ask you just very briefly about masks because to my mind, it seems as if masks are a simple, sort of relatively low cost intervention that can help to prevent viral transmission. I think we sort of know that we know enough about that, given that, the previous studies that have been done on other coronaviruses and influenza viruses and things like that. But I think I remember you saying at one point that there wasn't that strong an association between mask usage and the cases in a country. So what's your position on masks? Do you agree with them being a good intervention at this time?
Well, I think you're right there, Cliff, on one point, is that the costs of wearing masks are much lower than some other interventions that might be considered, such as lockdowns. So that's one factor to be considered. But the effect of the masks is interesting because, early in the pandemic, Ashley Bloomfield and all the infectious disease kind of people saying masks are ineffective, don't use them. And there's good trial evidence, which is generally considered top shelf evidence in epidemiology, to support that. And, people were doing studies with the optimistic frame in mind that it was going to prevent family transmission of influenza, that handing out masks were going to do that, but they didn't show a difference. And so now there's been a total flip-flop by the government to say now we're into masks. Public transport, yeah, I can see the rationale. It's quite a confined space. There's a few observational studies in aircraft where masks have been useful in terms of preventing H1N1. So I can see the rationale there, but in terms of overall, is this likely to dent the epidemic, dent the transmission? I've seen people throw at me case studies of transmission on public transport, so therefore masks must be useful. But just because it occurs in public transport doesn't mean that it's going to be prevented by wearing a mask. So the best evidence that I have is that they're not especially effective.
Right. Okay. I was sort of basing my belief, it might be naive, but more so on sort of indicative evidence of other cold and flu-like viruses, and studies where they'd looked at the transmission through the mask material itself, to sort of look at that as an indication of whether there is some suppression there of viral transmission. But yeah, I mean,
well, I think there's a plausible mechanism, isn't there? But I guess the lesson of epidemiology is that sometimes the plausible mechanisms don't turn out into health benefit. And, the best way we can test these hypotheses related to these biological mechanisms is through trials. And the trials, even though the benefits of, clearly make sense from a biological point of view, that the numbers unfortunately just don't support them. The observational studies, yes, there's a whole range of observational studies that you can find that support wearing masks, but in epidemiology we have this sort of idea of a hierarchy, and generally we want to go to the top shelf and go to the best evidence rather than just pick and choose whatever.
So would it be fair to summarize that to say you don't believe that it's necessarily going to markedly affect transmission, but there's not necessarily a negative to wearing them? So could a prudential approach be to just wear a mask because it's unlikely to cause any sort of negative outcome?
Yes, I think that's a reasonable viewpoint, but should we create this, I think the downside of wearing masks is that they perpetuate the fear of the virus,
Right.
which to me is, the evidence that I've pointed to is not justified. So if we all
Yeah.
mass mask, it perpetuates this irrational fear.
Well, that's a discussion I had with someone the other day. I was sort of positing that I think that there are going to be some positive outcomes from this, and that we've probably finally been forced to actually take some action against the pandemic. Because previously, with like SARS-1 and MERS and things like that, they kind of burnt themselves out, right? So we didn't necessarily get to this point, but any of us with an interest in public health have known forever. I mean, I was talking about this with mates 20 years ago, that there is going to be a serious viral pandemic. We all thought it was going to be an influenza pandemic, as most people did. But there was going to be one. There are going to be others. And so maybe this has at least helped to start to formulate some better strategies, but obviously we want them to be the right strategies. So with that in mind, right now, with this particular pandemic, what do you think are just the sort of bullet points of what you believe are the things we should be doing now to mitigate the effect of this virus?
Well, I think the flattening the curve idea was a good one, that we really did want to protect the hospitals, that we didn't want to see overwhelmed ICUs, and part of that was segregating patients. And I think New Zealand did that particularly well. They set up areas in the hospital for COVID and other areas that were non-COVID, so that COVID wouldn't spread through to vulnerable people, and particularly where the concentration of the virus is likely to be very high. So, and I think, in terms of avoiding disastrous effects or policies that other countries did in terms of sending convalescing COVID patients back into rest homes, or using them as sort of pseudo hospitals, that was something that New Zealand really did well. And I think testing around hospitals and rest homes for patients and staff is worthwhile. And I think serology would add another dimension to that. But in terms of a lot of the things that we're doing, in terms of shutting down borders, in terms of lockdowns, I simply can't support that in terms of evidence-based strategies. And I think eventually we're going to have to think about sustainable strategies that will allow us to develop immunity to the virus. I think the majority of us will eventually get the virus. We don't know in New Zealand yet. We haven't done antibody tests widespread. And we certainly haven't done T-cell tests. So we need to understand where we stand as a community. Are we naive to the virus, or has it actually been through us? In H1N1 times, it had been through us and we hadn't noticed.
Right.
And that was what the serology survey showed. 1 in 3 of us had a positive serological test to H1N1, and we were still trying to stamp out the virus.
Interesting. And I guess that points to a bigger issue too, in that we have an elephant in the room, right? We have a relatively unequal society with unequal outcomes, and that's socio-economic, and that plays into our health system. And I've seen very few people talking about health and metabolic health in relation to this, but to my mind, that's got to be part of the conversation going forward, because although, we don't want to be saying that anything is going to be a cure for COVID, I think anyone who's pragmatic is going to say that the healthier you are and the more nutrient replete your diet is, the better your immune system is going to be able to respond to threats. I mean, that just seems to me to be a very simple thing. And it doesn't seem to be something that's being addressed or looked at for the future, because, you know, this will happen again. And I would say that we just want to have a resilient population.
Absolutely, Cliff. Yeah, that's a good point. That's something that I forgot to add there, is that you look at who's doing badly from COVID, and it's people who have metabolic health issues. And we know that one of the greatest discoveries of my medical career is that, you know, it wasn't me. It was really me just tagging on to others' discoveries, is that type 2 diabetes is not an irreversible disease. That with diet, you can improve your metabolic health. You can reduce your blood pressure. You can get rid of the sugar and rid of the starch and do much better. So, yeah, I think it's a great message in terms of preparing for a pandemic like this, is that you need to optimize your resilience. And part of that, boosting immune system, is paying attention to what goes into your mouth. And uh, from an epidemiological perspective, the two greatest issues that we need to deal with is sugar and refined starches. And so it's yet another reason to do something about that.
I would also throw in there as a final micronutrient repletion. And the reason I say that is myself and many others have been heavily criticized for, at the beginning of the pandemic, promoting healthy approaches to eating and mentioning some of the things that we know from other viral infections, but just for their overall sort of importance to the immune system, the importance of having those replete within the diet. Things like vitamin A, vitamin D, zinc in particular. And people took that to mean we were saying that those things cured COVID. But that's a completely different thing. What I was saying and others were saying is that these things are necessary for the immune system. We're not saying supraphysiological doses. I was pointing to the New Zealand government data, which shows that, I think from memory, around 20% of people are not repleted in vitamin A. About 25% of people and 45% of men are not replete in zinc from diet alone. That's a massive issue, because those things are critical to immune function. If you're simply not getting enough to meet your RDA amounts, which are probably quite low anyway, it's unlikely that you'll be able to, you know, mount adequate immune responses against things. So it's not about cures or, you know, boosting to massive levels or anything. It's simply about having a diet that supplies what the working body needs to work effectively.
Yeah, no, I totally agree with you, Cliff. And you know that's all of what you said there is totally non-controversial from my point of view. That
And yet it's become controversial because people see it as, you know, that they see things that people are trying to find quackery within things that aren't in any respect controversial.
well, yeah, I think something that I've noticed here is that there's been a leap to make things sound controversial. You know, I was at a News Hub headline the other day: controversial epidemiologist says vaccine likely 4 years away. You know, that's something that if you do the research, you'll find that that is actually the gold medal time frame, and that hasn't been improved, and that the average is actually 10 years. So things that you know, it's actually the government, dare I say it, that's coming out with the controversial timeframes and the controversial policy. You know, you ask yourself, how likely is it that we eliminate this virus, given that 40% of cases are likely to be asymptomatic and not want to be tested? It's possible to transmit the virus when you're asymptomatic. The test is 70% sensitive at best. That that it's rapidly transmissible. It's very contagious. And you ask yourself, have we eliminated a virus similar to this in the past and with these characteristics? I can't find an example.
Yeah. Well, those numbers, I think, put a very strong full stop to this little conversation, Si, and I think people will have a lot to think about. So I just want to thank you again for having a chat, Simon. Whenever I'm feeling sort of unclear about numbers, I know that you're my go-to guy, and so it really helps me to clarify things. I hope that's both clarified some things for people listening, but also just caused people to ask some more questions and to take that idea that we can debate and discuss these issues without becoming ad hominem and without attacking someone, because if we do that within the environment of free and open academic debate, I think we're going to get the best outcomes. One final question though, are you going to publish any of your findings?
Well, yeah, good question. I suppose you saying publish in an academic journal, because there's plenty written already on the COVID Plan B website, and I guess part of that's just been that such a rapidly evolving thing that I've had to get stuff out that's topical. But yeah, there's I've been invited by the British Medical Journal to take part in a for and against elimination. So I've written something with a couple of co-authors on that. Yeah.
Fantastic. Well, we'll be looking forward to seeing that. I'll wait with bated breath and read that in depth. But I'll let you get back to your day, so I know you're busy. So thanks for joining me again today.
Thanks, Cliff. Appreciate it.